We are live now, up in the corner pocket. So take 1 second to share this out. There we go. I got 2 more shares. Okay, so good evening, everybody. I'm Dr. Michael Rocha. This is the Sunday night COVID-19 chat that we've been doing throughout the pandemic. I'm a cardiologist at Hawthorne Medical Associates. I also am the director of the New Bedford Wellness Initiative. And we've been fortunate to spend Sunday nights talking about COVID and how it affects our community and where things are at. So good evening, everybody. I'm Dr. Michael Rocha. I got it in. This is the Sunday night COVID-19 chat that we've been doing through. Leave that there. Okay. I had that in stereo because I had it on another screen, so bear with me. So tonight I am very fortunate to have a guest, Samuel Shem, or Dr. Samuel Shem, who is an author, a doctor, and I first got to know Samuel Shem when I read his now famous book, House of God, when I was an intern, and that was actually for me many years ago. And that book actually predates that. It was from that book I think was published in the late 70s, early 80s, and so he's written a book that has longevity for all of us in medicine, and still one that people are reading today. His current book, Man's Fourth Best Hospital, is something that I think is very important, and I'm going to give him an opportunity during our chat today to talk about that, and something that I just finished just a couple of weeks ago, just a really wonderful book. He is a clinical professor at the NYU Grossman School of Medicine, and I want to welcome Samuel Shem tonight to our program to help talk about COVID, help talk about health disparities, healthcare, and also about the protests. So Samuel Shem, welcome.
Thank you, Mike. Great to be here.
So I'm going to start off the program as we usually do, and just talk a little bit about the numbers and what's going on in Massachusetts. We know that we have 103,000 cases of COVID. We've lost 7,300 people to COVID, and unfortunately, many of those people, about 60% of those, are in the long-term care facilities. We know that the average age of people suffering with COVID is 52. The average age when people are hospitalized is 68, and the average age of death from COVID in Massachusetts is 82. We've seen a consistent decrease in the number of deaths. We've seen a decrease in the numbers, and that's partly the reason that tomorrow that we'll be able to move on to phase 2 of reopening the Commonwealth. So that is important stuff. In New Bedford, we know that at St. Luke's Hospital, the numbers are actually down. We have a total of 52 patients at St. Luke's Hospital that have COVID, and only 11 are in the intensive care unit right now. We've had 81 deaths in the city and a total of 1,910 cases of COVID. So again, that's the quick update, and I think that the trend in general has been very positive. I think that one of the things that we'd like to talk about today is things that are concerning certainly over the last couple of weeks that are important for us to chat about, which include the context of the protests that have been going on over the last week and a half. So I'd like to Shem, would you give me some of your thoughts as to what's going on with COVID and what your anticipation of what may happen with certainly the social climate of the last week and a half?
Well, I'm a proud survivor of the disease of the virus. I was I finally found out there are disadvantages to being a doctor and a writer because I was in New York City the first week in March doing appearances for my new novel, the sequel to The House of God. And I went to two very large medical systems, Montefiore in the Bronx and SUNY Brooklyn, and they really were inundated. But at that time, and this is a lesson. At that time, the only thing we had to be careful of, they said, was don't shake hands.
Right.
And I appeared, before 400 people at a time, and I had dinners and all that stuff. And and in fact, I found out that a very famous neurosurgeon at Montefiore died like 10 days after my talk. And so I came back and much to her dismay, I handed it to my wife because I didn't feel anything. Felt I was fine. And then we both got it. So at our age, it was a little worrisome. And as I'm going to have a piece coming out in the Globe of gratitude, actually, for writing and for surviving and all of that stuff. We didn't have to go to the hospital. I mean, I don't want to over exaggerate this. It was just miserable, and just took us weeks and weeks to get better. But one of the problems with being a writer and a doctor is that you go to hospitals for appearances, and you also, when you get sick, as you know, Mike, every little cough is a ventilator,
Right.
and every little shiver is you've got it. It's really horrible. So that's just the backdrop of what I talk from. The it's been a remark. I just will say, I'm old now. I'm 70. Just turned 75, and you have to understand everything we do is conditioned by forces that we really weren't aware of terribly much, right? That are driving us along. We think we're making decisions. Turns out, we didn't really know what we were doing. It's sort of like a flicker of a butterfly's wing from one side to the other, which way your life goes. And I was in Oxford during the 60s. I was at Harvard beginning of the mid 60s and then in Oxford afterwards on a Rhodes Scholarship. And so I look at what's happening now with just amazement and familiarity, and in fact, a lot of hope, because and I just want to emphasize that. I mean, what's going on? I mean, first of all, was the corona, which was miserably mishandled at the beginning. We don't have to go into it particularly right now, except that Columbia study showed that if the president had acted 1 week sooner or maybe 2 weeks sooner, he could have saved 37,000 lives.
Yeah.
37, and it wasn't until March that he really did anything. He waited 2 months. But what is wonderful is how the combination of the corona and then the falling economy, which is as bad as anything since the recession, and now with this comorbid system of the horrific murder of George, what's his last name again? Floyd.
Yeah.
And all of these things are coming together, and it's very similar to what came together, although in a much lesser way, or more in some ways, way back in the 60s, that resulted in tremendous change. And this is going to, I think, result in tremendous change. And why am I talking about politics in terms of COVID? Because, one of the things that has been brought out in absolute clarity now, absolute clarity, is the insufficiency of our healthcare system in general, but especially for people who are underprivileged, mostly people of color. And we got to do something about that. I mean, my effort, even before these things were happening, my book came out in November, Man's Fourth Best Hospital, and it's all about the modern healthcare system. And it's no wonder that we are in such a mess now with this. But the big message is you don't have to be a genius to know that all the signs of this period of American history, in a way like the 60s, is going to result in important changes for everybody, including, I believe, much better public and private healthcare.
Yeah, and I think, like you said, though, it's the disproportionate effect on various groups of people in this country. It's been very clear that our healthcare system has not been able to equitably take care of everybody. And I saw there's a cardiologist, Clyde Yancey, out of Chicago, that had written something in JAMA just about a month ago, and his article was very clear, and I thought it did a nice job of talking about the number of cases in Chicago. 50% were involved Black individuals, and 70% of their deaths at that time involved Black individuals. And obviously that's a huge disproportionate number of people in the community. And again, there continues to be so many different ways that people are looking at these things as to, how does that happen? And, what we also realize as physicians is that we talk about, not just healthcare, but health, and, how important, again, wellness, well-being, putting an emphasis on creating communities that are healthy. And we haven't really invested in those kind of things. We invest in sick care in America, and it's also extremely expensive. The health insurance industry is probably doing just fine right now, but again, the health of the population is still struggling. And I think that what we saw also is that a healthcare system that is not able to integrate quickly is not able to manage and be flexible enough to really be able to take on the challenges. And certainly we all, in this region cringed watching, first what happened in Italy and then what happened in New York. I mean, friends of mine, I have a friend of mine who's a cardiologist down at Mount Sinai, and she unfortunately got very sick with the virus and required hospitalization 2 times. And fortunately for her, it just avoided going into the intensive care unit. But again, the stories of what was going on down there in the front lines, it's interesting for me to have conversations with some of my colleagues up here, because they don't really fully appreciate how difficult it was in New York in which to take care of folks. So our healthcare system can certainly do better. But I would also say one of the things, though, is the system can do better. But I would tell you, my experience with the actual people that have been on the grounds and doing the work has been absolutely remarkable. And I would say just at St. Luke's Hospital, everything between the staff, whether it's the unit secretaries or the nurses or the aides or the therapists, and or just the people that are, that are housekeeping, really have done a remarkable job. And it is really, it's really impressive to see, like you said, in these instances where people come together and change will happen. Because I think that in a way, for me personally, as a cardiologist, I was having conversations, weekly with cardiologists from pretty much from all parts of the country, and we were able to come together. And it wasn't really an academic thing. It was, we all signed up for a Zoom meeting, and everybody was sharing what they were doing, and doing it in such a way that was transparent, right? So usually it's like, I'm going to hold on to my ideas here, and we're not going to share it. But the amount of sharing that went on in medicine during the pandemic, certainly in the crisis period, was really quite remarkable. And I think that's something that will continue to grow after this.
Yeah, I just writing an op-ed piece about exactly that. This puts in a real spotlight the way that all of us doctors, nurses, all of the other people, I can't even name all the different tribes that come into to take care of these people, but we all did what we were trained to do, which was to stick together, go to the max, be honest, be not afraid to put in incredible hours, because we had to save these people. And we still don't go into medicine primarily to get rich.
Right.
We really don't. We go into medicine because we want to help people and we want to be present at the most important times of suffering in their lives. And all of a sudden, we had a big one, a real big one. As somebody said to me, you can't pay someone enough to have that be the reason that we're doing what we're doing. It's not about money. We swore an oath. We decided we were going to try to relieve pain and suffering. And the greatest thing that happened among almost to a person, actually, from your experience, you jump in and you do what you basically have to do. And the important thing, I wrote a piece for the NYU bulletin, NYU Medical School bulletin, and it's called "Why Do We Walk Toward Danger?" Why do we walk toward danger? And nothing, not even the Hippocratic oath that we take, makes us do it. Oaths, you don't march into danger for oaths,
No.
right? You march into danger because you are connected to a group that when you start to go down, they lift you up. And when they go down, and the connections in every theater in the hospital with this drama were what got us through. Now, the other side of that, okay, and this is partly what I was writing about, this op-ed piece. I don't think people know that during the corona, in the last 4 months now, 5 months, the profits of insurance companies and the stock prices of the big insurance companies have gone like this. They're off the charts, off the charts. Why are they profiting from this? For two reasons. One is there were no elective surgeries or non-corona admissions to hospitals or to doctors' offices. So they're not paying any money for the care. It's gone way down. Meanwhile, all of us, you and me included, right, are paying our premiums in. And you know what? Last year, the two top guys at United. Whoops.
Oh, still there.
Uh-oh. Hello.
Oh, I'm still here. Can you hear me?
I can hear you. Can you hear me?
I can. Yep.
Well, the screen went blank.
You're still there. I can see you.
Oh, all right. Well, that's good. Oh, there you go. Oh, I just had to click. Yeah, I got to the climax of the thing. The two top guys at United Health, is that the name of it?
Yeah.
Biggest insurance company in America, in the world, I think. Last year, they made $50 million each.
Yeah.
And you ask why we don't have health care for the poor, or we don't have really, why we spend $10,000 a year per patient in this country, the highest in the world. And we're, in terms of quality and safety of care, we're down to 34th or something below Togo or something. You
Yeah.
ask, why do we have a problem? We have a problem because you can't take care of patients in a private system, that because people can't make any money at that, and they're not going to do that. So that's, you can't, what I'm saying is, when the patient is never only the patient. You know this, when you go into when you go into a patient's room when things are normal, the patient is not only the patient. It's the friends, the family, the where they come from, what they're eating, where the water comes from, where the garbage goes. And you can't talk about a pandemic like this without talking about all the different things that are interrelated. And in the book I wrote, Man's Fourth Best Hospital, is all about the suffering that is caused really by this out of control private industrial complex of medicine. We got to change the system.
But I think you touched upon the social determinants, and that's probably why things are disproportionately, again, falling upon certain groups of people in this country. Is that again, when we look at in Dr. Yancey's piece, he talked about again that we do know in COVID that the people that are going to do the worst are the ones that are older, but also high blood pressure, obesity, diabetes, and again, for what I take care of, cardiovascular disease. And unfortunately, in the racial and the ethnic minority groups, in the Black population, the percentages are higher. And unfortunately, those people, again, are also, as I've seen several pieces in many different articles talking about, again, that there's a higher percentage of people in the minority populations that have to go to work. They can't socially distance. They can't necessarily be at home, and again, they may experience a higher level of these various chronic diseases. And again, it seems to be very unfair. And I saw something the other day. There's a task force in the state talking about we are looking at overall our numbers as we open up, but we're not really actually looking to see that, again, the various groups, we're not breaking it down very well to see which groups of people may be most vulnerable. Maybe our overall trend for, less cases, less hospitalizations and death may not be it may not be for every individual group. And these are the things that, these are important to talk about. And I think that now, certainly in the midst of the protests and, again, looking at equity, is certainly something now that's been really brought out and amplified, so to speak, with, between COVID and now, the protests. One of the things that you see now is, we've been trying to socially distance, and now, again, given what's happened over the last couple of weeks, people are coming together, right, to protest, the injustice of what happened. And now we've had people that, there's a variable, you see the pictures, not everybody's using a mask. There's a lot of chanting and yelling. We've seen that tear gas has been used and pepper spray and all these other things that, tear gas is going to potentially cause people to cough, which is, maybe something that spreads the virus, or, the pepper spray and these various things. And, not everybody's wearing a mask. So, we look at these things now, and, we've kind of got there's a little bit of trepidation as to what's going to happen in the next 2 weeks with, the interplay or the intersection of COVID and the protests. And again, I don't think that because of the way COVID acts, people don't have symptoms typically for 5 to 14 days. We're not going to know what this looks like for, a couple of weeks. And that's a real challenge. And, I've seen several pieces, and, I don't know what your thoughts. I mean, at this point, what do you think of some of the safer ways that people may be able to protest? And I've seen various things out there, and again, but I'm not sure what your thoughts might be on it.
Well, why don't you say a couple of things that I'm sure
Yeah,
you're
no,
quite.
I mean, one, the masks, but I saw something interesting the other day that someone had suggested bringing goggles and nasal spray, so if they had pepper spray, that it actually would cut down on potentially the response, the sneezing or the coughing that may come about. So it's just, I'm not so sure that that's going to happen where everybody's going to bring goggles to the protest, but I think that the other things I saw was it's using noisemakers or drums or signs rather than the yelling and the chanting, because again we know that you spread COVID further by yelling or loud singing is another one. And these are the kind of things that I think that a lot of people in public health, a lot of doctors are concerned about and not sure what's going to happen.
Yeah, well, we faced this today because we're in Boston and our daughter has come to live with us for her graduate program at Arizona State University, and we kept her, quarantined upstairs for. She was just about to come out today, basically, and she said, "Well, I want to go to the Boston rally."
Yeah.
And we we had a very good talk. I mean, we didn't say yes or no. We listened to her, and finally, she's a pretty cautious kid in a way, although she's had all kinds of adventures. That's a good way to be cautious and then have adventures rather than the other way around. And so she didn't go. Yeah, there's no way not to have this now.
Right.
And as I said, I think it is the thing that has had to happen in order to bring change to lots of things, especially in healthcare. What's the number one? What's the top thing that people are concerned about? Number one for the election. Number one, healthcare. Number two, healthcare, and then maybe equality. Um, I don't know. I haven't really. You can't stop this. You can't stop this. It doesn't matter what I think or you think or anybody else thinks. This is an organic rising up that I have never seen before. I mean, in the civil rights movement, when, as I said, when I was in college, um, there weren't all that there weren't all that many mixed crowds with every kind of color uh, and status in the country. This is everybody. You look at the crowds, there's everybody there. Everybody's there. And I'll never forget our daughter. It made me think of this. Our daughter, when she was probably about 5, something like that, and she was in preschool or whatever it was. And she came home and she said, "Oh, I made a great new friend. He's a boy. He's a great new friend. I'm so glad to meet, blah, blah, blah." We asked about him. Oh, he's just a nice guy and all that stuff. Then we went to school to pick her up the next day. He was black. She actually is Asian. We adopted her from China, but she was black. He was black. And in my day, the first thing I would have said at any age is, "Oh, he's a Negro." Or he's black, a Negro in those days. He's black. So there's this now, her generation, she's 28, her generation's a big part of who's out there. And they don't have the same ideas about race. So this is a step that I am so glad to see. Anyway, to be a little pragmatic, um, as you given your numbers, these are not kids that are the main ones that are really getting really sick from
Right.
corona. They really are not. I mean, those, especially if you go to the death data. I mean, that's amazing. They may have to go through a lot of stuff, but you can't stop them. But when I'm trying to look at the good side, I'm an optimist in case you haven't noticed. Um, and they sort of are trying to wear masks and stuff like that, but as you know, it's a very difficult virus. So I let them do it. I mean, they're going to do it. So warn them, tell them what to do. I don't think they can. I think we will see the rate go up. I think, um, some of the gatherings, the anti-gatherings in the past, where people are, flagrantly not wearing masks. I mean, come on. Most of the people are wearing masks as they can.
Yeah. I think what you said is important. And, I talked about this last week. The case fatality rate for people that are younger, especially younger than 60, is very different than those that are older. And I think that, again, we do see cases of people in their 40s and younger that have had severe disease and gotten sick. The good news is, if you look at the modeling from the CDC, they said that the overall, it's 0.4 percent of people will die from COVID, but it doesn't speak towards the older population. And like you said at the beginning, your concern was, you're 75 years old, and that puts you just based on age at a higher risk. And we do know that for people, at every decade after 65, 75, 85, the risk of death goes up. So, one of the things to not only do, the reason I think that for people to protest as safely as possible is not just for themselves, right? Because they're younger, but it's also about bringing it home. And I think that one of the things that I've seen is that, people should really have a low threshold to get tested. And really, if they're sick, they need to stay away from family members. And as we said before, for certain populations, that idea of being able to, distance in your own home is a real challenge. And, that may be disproportionately affecting people that are in minority groups. And, those are the kind of things that, could have a real impact if, you're living in a situation with multi-generational family and people are on top of one another and they're not able to distance. Then, you're going to have a situation where, even though the person who's protesting is okay, but, we don't want to see it spread to those that are going to be the most vulnerable. And I think that, my message to people out there is that, again, like you said, this is important stuff that we're talking about. But how do we do it in such a way that, we limit the number of people that, that really get sick from this? And I think that's, within the protesters, et cetera. It's one thing for me to say it, one thing for you to say it, but what it really needs to happen is the people that, are putting these protests on, they need to have that conversation with the group of people that they're with, or the people that they're organizing, and they need to make it a priority. But one of the things in New Bedford that's been nice, so a couple of things in New Bedford that I've watched that have been, there's been a younger group of people that have organized. There's been a younger group of people that have made their voices heard. They've done it in a peaceful way. There's been a lot of mentorship in this community, and even at the only city that I'm aware of in the country that has been giving free masks away. So yeah, so we have 6 different wards, and so far through last weekend and this weekend, we've gotten free masks out to wards 1, 2, 3, and 4. Next weekends will be ward 5 and 6. And one of the things that's been happening is that we've been getting that the city has been able to also provide some masks for people at the protests. So that's the kind of message, and also, for people that are protesting, amongst those groups, again, kind of making sure that everybody's, doing those things to keep people safe, because we have to be able to do both of these things, both effectively and safely, in order to kind of move forward. And, so I guess there's a couple of different ways of different things to look at here. And I guess my good friend, Dr. Michael Fine, who put a comment and a question in. So I think, how do we organize to change things? And I think his question was mainly how to change healthcare. But, I guess, how do we organize, several things right now to change? How do we organize around the equity issues and health equity, et cetera? But how do we organize towards changing healthcare? What do you think?
Well, when I started to write the book, Man's Fourth Best Hospital, I did it because I get really steamed up at something that's unjust, right? And with my first novel, The House of God, as you know, the injustice that I had experienced, that I wrote about, was the treatment in medical training of young doctors. And that has actually changed things over all
Yeah.
these years, you know. And so all of a sudden I got a call. I was out of medicine, but I got a call to would I like to be a professor at NYU Medical School, NYU Grossman Medical School. I said, well, why? Why do you want me to go there for? And he said, we want you to teach. And I said, what do you want me to teach? This is about 6 years ago. And I said, and they said, well, we want you to teach the house of God. Now, you have to understand the house of God was just really hated by the medical establishment. And they did a lot of bad things to me in public and private about it. But now it's a classic. And here I have a institution that wants me to come. I said, what do you want me to do? And they said, we want you to teach. What do you want me to teach? The house of God as I said, in a seminar and part of their humanities program to medical students and doctors. And so I had always wanted to write a sequel to this book, to this classic one, House of God, but I had been out of medicine. So I went on rounds at NYU and I saw the miracles that medicine can do there.
Right.
Absolutely. You cut off almost anything except the head, they can replace it, you know.
Right.
Maybe they can do that too now. I don't know. But all of a sudden, I saw loud and clear two things that had happened that I hadn't really known much about on the wards. And as the narrator of the book says, he says, I'm called to write this novel because it was a time when medicine could go either one or two ways, either toward more humane care or toward money and screens, you know, the computers, which means, as you know, but the public doesn't know, means money and money, because the screens are not primarily helpful to your care. The screens are billing machines. Your doctor, there's a war across these screens. Your doctor, on the one hand, is typing in and he's being urged, if not coerced, to find the highest payment for the work he's done. And on the other side of the screen, the insurance person is being forced to pay the least.
Right.
And this is driving doctors nuts. You probably have talked on the show about physician burnout. When the electronic medical records, these billing machines came in 2008, was the beginning of the epidemic of burnout in doctors and nurses. It can be shown. So what can we do about this? How do we change things? The book is about this hero from the first book, this wonderful doctor called the Fat Man, and he knows everything. He's a great guy. And since man's fourth best hospital has fallen from being man's first best hospital, the people who run it are getting very nervous, and they need somebody who has prestige and money. And the Fat Man has both. So they bring him in and they say to him, you can do anything you want here. Just, you know, help. And what he wants to do, and this was my job as a writer, I took this very seriously because I was so upset at what I just said. He said, because he's sort of another version of me, the Fat Man said, I want to have a public clinic up against man's fourth best hospital, this big hospital, and I want to show how to put the human back into medicine, how to put the human back into medicine. So it was my challenge to show in the book what's wrong, which I do, and then what to do about it. And for the what's wrong piece, the Fat Man gives a lecture in the middle of the book called The Six Rackets of American Healthcare. Follow the money, right? And all this interwoven thing. It took me 2 months to understand this. Nobody knows what's going on. And then at the end, he offers what to do about it. He gives another little lecture about what to do about it. And the first thing that he says I put it in very simple terms so anybody can get it. Because your doctors are spending almost, 60% of their time typing into these screens, depending on the specialty. He says, quote, we gotta squeeze the money out of the machines. We gotta squeeze the money out of the machines. And what he means by that is no billing and arguing with the insurance person about how much money you're going to pay the hospital, right? And the model for that, of course, is the VA system or Medicare, because the doctors love working on the screens at the VA system because there's no argument about how much to get paid for, say, an appendectomy, because all across America, the basic price of an appendectomy is the same.
Right.
There's no more dickering about oh, I got to go to war again for 60% of my day with insurance companies. So that's a long answer to what's going on. But what we have to do, and what's going to happen, I'll tell you. We've got to have, we almost do have it now. And we've got Medicare, we got Medicaid, we've got the VA. We've got to get some kind of national system, right? A public system that everybody can use. They want, they don't want, okay, but they got to pay, et cetera. And we also can allow the private health system to exist. And so what would happen, but with one requirement, and that is when I, as the surgeon, am typing in the code for a government system like the VA for appendicitis, I finish that. It takes about 50 clicks, okay? And you're done with that. And then you look up, oh, does Michael Rocha have, is it Rocha or Rocha?
Rocha.
Rocha. Does he have private insurance as well, supplemental, like in Medicare supplemental, right? Oh, he does. Okay. You hit click once, send it to the for-profit insurance company. You're done. And if they want to get paid more, let them do it on their computers, not mess with ours. Simple as that. There has to be other things like tort reform and also the Shem system for a national change. It has to be, and NYU has already done this, of course, is that you make medical care, you make medical tuition free. Becoming a doctor is free, but the doctors, after they graduate, have to spend at least a year, maybe it'll be 2 years, doing medicine in some place in the United States that's underserved. And whenever I speak at graduations, and I say, would you take that deal to medical students who are graduating? Every hand goes up. Every hand goes up. It'd be fun.
Was it NYU lingo? Didn't they make medical school free?
Yeah. My school now, it's an amazing place. Amazing place. They worked for I think 10 years with the new dean who's still there. They worked for 10 years to create the funding so they could do it. And they did it a year and a half ago now.
Yeah.
It doesn't even matter if you have money or not. It's totally.
Yeah, I think the other thing is because really we've set up healthcare as a market system and people don't even know what the price of things are, and it can't function that way.
That's right. That's exactly.
And again, it's the system that's in place has put the doctors and it's put everybody in between one another. And most importantly, again, and I'm actually going to give a quick shout out to somebody that you had, I think, dinner with recently, Dr. Bernard Lown, and been a mentor for me, and also his book, The Lost Art of Healing, Practicing Compassionate Medicine, is really probably the most. Don't take offense, I love House of God, but that actually was perhaps the most important medical book that I've ever had. And he's 99 years old today.
Today, good.
Today is his birthday, so I want to give a shout out, Dr. Lown. For those of you that don't know who Dr. Bernard Lown is, take the time, Google search. He's a giant amongst doctors. He has a Nobel Peace Prize for his humanitarian work surrounding nuclear disarmament in the 80s. His contributions to cardiology throughout his illustrious career are amazing, and also his just incredible character and again, somebody that really has never liked to see injustice and has really done incredible things. Dr. Lown, his book, The Lost Art of Healing, Practicing Compassionate Medicine, was 1997, and it's still valid today. And it's still exactly what we need to do is we need to rebuild physician-patient relationships. And it's listening, truly listening. And one of the things is hopefully now that maybe people's ears are open now, through COVID. Now people are willing to listen because now we can see that, because we haven't had an integrated system to really take care of things. How scary has it been, right? It's been really scary, when everybody has these little market systems in healthcare and isn't integrated, how does this work? And again, we have way too many barriers of working together in order to really to take care of people. I mean, again, it took a lot. We've talked about personal protective equipment. I think this state has done a pretty good job of trying to understand, who has the most, who's most in need. They set up a group, and that's not even perfect, but we need to. And also, I mean, the poor nursing homes really weren't equipped for this and for personal protective equipment and staffing, et cetera. And, we need to understand better as we look back, and not having an integrated system and not having, the ability to work through, to remove, I should say, these barriers is evident. And so
I would say, to put it very simply, in terms of what's wrong, the one biggest thing that's wrong with the healthcare system and is responsible for all the stuff we're talking about is that the private for-profit health insurance companies don't want to provide health insurance. They make the most money if they don't provide health insurance to people.
Right.
That's their. So you got a health insurance company that doesn't want to help with health insurance.
Right.
It's crazy. And what I sometimes say when I'm talking about this stuff, when people ask me what can doctors do, for instance, or doctors and nurses, I say, well, have you ever in a crowded theater, if somebody falls down, a shout go up? Is there an insurance executive in the house? No.
They don't.
And we go back to basics. We're the workers.
Right.
Without us, there's no health insurance. And doctors are terrible about getting together and saying, no, we're not going to work this way anymore. It's not fair to the patients, not fair to the doctors. The nurses are good with it. They have a union. They almost always get what they want, the nurses. So what we need is kind of to join with all the other players, nurses, doctors, patients, even hospitals, because hospitals are getting screwed by this too. They're always fighting the insurance payments, right?
Right.
We got to get together and just say, no, this is okay. You're debating your Medicare for all. Oh, okay. We have a million doctors. And we can't live on Medicare salary alone. That's the big argument for doctors, and we said, you pay. We're not going to work basically unless we get paid what is reasonable for us, probably around what we get now. You don't get terribly rich, most doctors.
Now, I think when we're talking about inequities too, again, there's a large. Even just amongst, for example, now with insurance, who's insured and who's not insured, and there's a lot of people out there that, again, in minority groups that may not have insurance. And I think that one of the things that's important too is where does the delivery of care happen? And again, we've traditionally put an incredible amount of effort into the ivory tower sick care, right? Surgeries, et cetera. Again, even in cardiology, I mean, there's great advances. Ability to treat a heart attack, the ability to treat valve disease, has transformed even in the last 5 to 10 years. Those with advanced heart failure that I've taken care of, transplant, LVADs, all these other things. It's not about, these things are important to have those options for people that are truly sick, but again, we spend such just lip service on the delivery of what I think is really high quality primary care. And the question is we need high quality primary care, which needs the time to truly listen and develop a relationship. I feel for my colleagues in primary care because they're again, they're trying to see more and more patients to try to again to there's a lot of various pressures there, both personal pressures, but also pressures from the healthcare industry, and we have to go back to putting high quality primary care. So the delivery of care is, and where does that happen? Again, traditionally, we have, one of the things Dr. Fine has been a huge proponent and actually has been integral in working in really transforming some of the community health centers that, again, back in the 60s, community health centers were supposed to be the hubs of care for everyone. And, again, we have great doctors there, but we really haven't done a good enough job of really supporting those places to do the incredible work that they're doing. And, we have to talk about, not only the insurance and healthcare, but, where does it happen? What do you think about that?
Well, it's happening, actually, except in the rural areas, which are just being forgotten, as you know, the statistics. But what my experience is in New York, I can only speak really for NYU, Grossman Medical School, and the hospitals there. I think they're being really smart because they have a tremendous number of general clinics all scattered out throughout Manhattan, as well as and in Long Island and Brooklyn now. And it's a consolidated network, so they have all the resources from the big hospitals. I mean, there are 47,000 people at NYU,
Right.
And they have all of the advantages. If somebody gets really sick, they have great, as you know, great hospitals. The sense of service to other people is really very big, very, very big, and people are happy there. So they have satellites all over. They're integrated, and actually, what we're doing, Zoom, has absolutely, I think, changed things for forever, because people learn they can do a lot of stuff on this. Doctors and patients can do a lot of stuff on this. That ain't going away. I was a skeptic, but this is really good. I really get to know you on this thing.
Yeah, no, it's
go
been
ahead.
very helpful. It's been very helpful for me to be able to connect with people that aren't able to come into the office under these circumstances.
Absolutely. So I think the good part of what's happening is that there are models for how to take care of people in smaller satellites, with nurse practitioners and stuff doing a lot of the work, and having one doctor, say, or two supervising, right? With any kind of hospital that if they need it, they're right there. They can get first by Zoom, say, and then afterwards, boom, they get admitted. And that's happening. On the other hand, the hospitals are terrific. I mean, they just built up another hospital at NYU, General Hospital. But the issue really is because of this is a huge danger. The for-profit, for heavy profit hospital chains now are really causing a lot of trouble. Now they're privately owned hospitals. Hedge funders, Wall Street people are betting on these hospitals. These are investments. They make huge amounts of money because they know how to make money, and they maybe don't treat their staff as well. I don't know. But They are forcing rural hospitals to close. They can't compete with them. So that's a real big problem in the whole United States. There are people who have to, even in a little town, Hudson, New York, where I come from. I keep tabs with them. I know all of them, just up the Hudson River. Uh, the hospital was bought by whoever knows. I don't know, some big conglomerate. It'd been there, ever since forever. And all of a sudden, I read in the paper there will be no obstetric department in this hospital.
Yeah.
No pre-birth, no deliveries, no deliveries. They are 40 miles from any other place that will do a delivery. Imagine that. Why? Well, you know why. A, things, the OB doesn't pay that much. And B, when it goes wrong, you have to pay, for bad care often.
Yeah,
So I think if that's right, I don't know. Maybe I'm not right about this.
yeah, I think what you said though too, care has to be in the community, and I think that's, and again, primary care doesn't happen necessarily in urgent care, and I think that's another thing that we need to realize is that we need to have more primary care, and like you said, I think that people would be more apt to go into primary care if they didn't have the large debt.
Mm.
And,
Right.
and also we really need to cultivate where it happens in your own community. And I think that, that that's where it needs to happen. And we
Yes.
we need to address, when we look at things that are not fair at equity, we see that people disproportionately are struggling with high blood pressure, diabetes, or obesity. We need to understand that it has to do with, access to healthy food. You really need to be close enough to pharmacies, or able to access healthcare. Because for some people, they're even in our own community here. It's hard for them to get to visits, and we need to break down those barriers where people are able to access care in their own communities. And I really think that that's part of the movement in the delivery of care. Again, I think that we have, like you said, we need to have a much more integrated system, but we have to also envision where it's going to happen, because it breaks my heart to see when again COVID takes the cardiovascular patients, and unfortunately I've lost some of my cardiac patients because I know that they're older and they had a bunch of comorbid issues and had heart disease, and it breaks my heart that we should do a better job of preventing them from even having heart disease, and I look at it sometimes, that a good hospital or a good community is one that's having less heart attacks. And there's instances. San Diego's been able to really focus in on the again, simple things like blood pressure, healthy diet, um, you know exercise, not smoking. And these things do make a difference. But sometimes when we talk about these things, people just kind of roll their eyes and go like, yeah, we know. But the difference between knowing and doing those things are very different. And
Well, I know we're running out of time, and I'm glad you said that, because my message to when I talk to doctors, when I talk to patients, when I talk to anybody, is um, is exactly what we have to do as a country, and which is happening now more with all of this protest and people taking responsibility for making things better. And
yeah,
that is, connection comes first. Connection comes first. I mean, when I decided to go out speaking, as I said before, I was prompted by injustices that I saw. And what I have done my whole working life is to write about the danger of isolation and the healing power of good connection. Good connection is good medicine, and good connection is good living. I mean, otherwise you're alone. And I remember the thing that got me out as a public person, because I was a very shy person when my first book, Man's Fourth, came out. In those days, there was no email, so I had a pen name, and that people couldn't get to me. One day, I got a letter through my publisher, and it said, "I'm on call. I'm a doctor on call in a VA hospital in Tulsa, Oklahoma. And if it weren't for your book, I'd kill myself."
Wow.
And I said, whoa, that's what I said. Wow,
Wow.
maybe I have something to say. And I started speaking then, after not saying anything for 2 years. In 1980, I started speaking, and I've never stopped. And my message is always the same. And it's not just for doctors, it's for a society, it's for the people you love, it's even for the people you don't like. Connection comes first. You know, if you connect, you can go anywhere in a conversation or in a healing. And if you don't, you're kind of lost.
Yeah, I think the connection and listening are one of the. I mean, we have so much noise in this world, and again, we have to really take the opportunities to understand. Again, that we have differences, but there's still more. There's still more that we probably agree on. That again, and I think that one of the biggest challenges is labels, right? And for me, um, it's amazing when people label themselves one way or another. It makes it really hard for them to actually disagree with the group that they may align themselves with. And I think that that's made it very challenging in our country. Because we really need to put down our guard and put down our labels and really focus mainly on issues and ideas. And I'm hopeful that as we move forward, that again, like many things, the protests are important, but the next steps, or what we're going to do in healthcare, is to organize people to come together in such a way that there's going to be a sustainable movement, and that we need to think about what our actions are going to be in order to change that, right? So we need to think about what things. At first, I think that as we kind of come through this, is to kind of sit and in some ways to brainstorm about what we're thinking about. But at some point, we need to figure out what do we want to see. What is the next step that's going to move us towards, again, for more universal healthcare, or at least a discussion, because you start to talk about universal healthcare and you get many of these things become polarized until we really start to listen about what does all that mean, right? And then people realize, hey, wait a minute, that's right. I want to be able to have care that's reasonable and not be price gouged and all those other things.
Not be one $450 check out of your, and you're done. No, I think I would use a very strange word at this point in our nice, wonderful conversation, Mike, and that's spirit. Spirit, which means I don't think that spirit or spiritual, a spiritual life or work is beyond the self.
Yeah.
It's the we. I see it as the we, and the we means I and you, but it's the we. And I think finally, after a long period that has not paid attention to the suffering of lower class people, especially, I think I would say that these demonstrations, mostly peaceful, uh, are showing what is, I believe, an indelible spirit of this country. I don't know where you grew up, but I didn't, I
I
didn't
grew
have
up
much.
in Bedford.
I didn't, I wasn't rich by any means. We got along, but I think there is a spirit that comes when people uh, see an injustice and um, get together and take action like this. And the reason that I'm so sure about saying these things is because in the 60s and the early 70s, of course, by putting our spirits together and non-violently protesting, we put the civil rights laws on the books, and so that's what's in my blood. That's why I'm optimistic about this. This is in some ways even better. What people haven't didn't live through that time. There were 40, oh, sorry, there were 4 assassinations within 18 months,
Yeah.
right?
Right.
Kennedy. And people were burning the cities down. They were burning, and people were getting shot. And at Kent State, 4 poor college students were just mowed down by
Right.
the Ohio National Guard. So it isn't even as bad as that. And I think the spirit is rising.
Yeah, I do. I think that, people are able to see the inequities, and especially the health inequities that, gone through COVID, and also that amplified through COVID, and also, again, our concerns. And we want to keep everybody safe out there. I hope that people have tuned in and maybe got something out of this evening, and our discussion about, how to stay safe. Again, for those that are out there that have been protesting and you're concerned, make sure you get tested. Make sure that if you're sick, you stay away from family members, or do the right thing. Stay in contact with your doctors, because COVID is not over. And we have to, again, just because the state has started to reopen in certain ways, we just still need to continue to be vigilant, and just realize that we continue to do these programs because we care. I mean, ultimately, this is, for me, New Bedford has always been home, and I'm actually very grateful for the opportunity to be back here practicing. I'm also very grateful for the connections that I've been able to make, not only in the city, but also with, Shem, for like you said, connection comes first. And after I finished reading your last book, Man's Fourth Best Hospital, we have a mutual friend, George Mumford, who was able to connect the two of us up. And
was that George Mumford?
yeah, George Mumford was the one that connected the both of us up. And ultimately, that has given us, the opportunity to talk about, your book and your vision. And I think that the both of us share a lot of like-minded goals and insights for, where we can do better. But I agree with you. I really do think that despite these real challenges, I think that we're going to be better off after COVID, after the protests, after having these discussions. It's forced us to have discussions that we haven't had before in a very meaningful way. And I hope that if we can continue to do that with respect for one another, that we really will find, again, a country, healthcare, and really just a world that is better off. So I know it's whenever you're in the middle of the storm, you see the hurricane swirling around. It's how do you maintain that calm and have the ability to see the light, see the good things that are coming out of this. So I'd like to give you a couple moments, if you'd like to give a few closing thoughts. We're a couple minutes over, but I think we're okay. Again, I want to thank you so much for your time tonight and for coming on and having this chat. But I'm going to leave the floor to you to have the closing comments this evening.
Okay, well, I've already gone toward the spirit. I mean, you can't go much further or deeper than that. But let my novelist side talk a little bit. I've been mostly a doctor on this. I think if you want to understand the American healthcare system and have a lot of laughs as well, go buy the new book, Man's Fourth Best Hospital.
I agree.
I took on a challenge to describe it in an amusing way as well as in a passionate way, and what to do about it. So, it's out there.
Thank you.
Amazon, of course.
Yep. Everybody have a wonderful night, and thanks for tuning in. We're going to do probably one more COVID-19 chat next week. My guest next week will be Dr. Aaron Bromage from UMass Dartmouth. And anybody who hasn't checked out his stuff, aaronbromage.com, he's been talking about COVID and some of the practical ways in which to kind of prevent both the spread or catching yourself. So everybody have a great night. Thank you, Shem, for coming on with me, and I look forward to continuing our conversation. Be well, safe, everybody. Take care.
Thank you.